Good morning, everyone, or afternoon, maybe possibly even early wee hours, depending on where you are listening in or watching from. Thank you for joining us today for our AIM Center quarterly webinar, where we will be discussing collaborative care, providing collaborative care in rural settings. I am Monica Harrison. I'm a clinical trainer and practice coach with the AIM Center. I'm also joined today by my colleague, Christy Malmstrom, who is behind the scenes helping us with some of the logistics here. For those of you not familiar with our work here at the AIM Center, we help support organizations implementing the collaborative care model through coaching and clinical training. Since 2017, we have also developed technical expertise in billing and financing collaborative care and have gained national recognition in this arena. The purpose of the AIM Center is to inspire providers, researchers, and decision makers to transform healthcare and improve patient outcomes. We accomplish this by translating and researching evidence-based approaches to behavioral health integration. This call is being recorded, and we'll be sending out a link to the recording and the slide deck to everyone who is registered. This webinar format accommodates our large audience today, and you'll see on your Zoom screen that there is a Q&A function. We're asking you to use that instead of the chat box to enter your questions for the presenters. You can enter those at any time. We'll only answer the questions after all our presenters today have spoken and we've concluded that portion. Today, we'd like you to focus your questions on experiences of these expert presenters. And if you have general questions about implementation or financing collaborative care, please bring those to our implementation or financing office hours. You can also check the FAQs on our website. Those links will be put in the chat for you now for you to be able to access those. At the end of this session, participants should be able to discuss the evidence for collaborative care in rural areas, list how collaborative care can meet the needs of a rural population, and provide practical tips for overcoming common challenges and providing collaborative care in rural areas. So today's presenters that I have with me are Annie McGuire, Dr. Orrin O'Connell, and Stephanie Hoover, that will all be speaking to you today about their experiences with and knowledge around collaborative care in rural settings. So I will turn it over starting with Annie.
Thank you, Monica. Okay, thanks, Monica. All right, I'm going to just start us off with a little bit of background about rural health communities. And residents of those communities face significant social and health disparities compared to urban and suburban residents. Rural residents are older, typically poorer, have lower educational attainment, and are more likely to be unemployed. So the poverty rate in rural areas is about 15% higher than urban and suburban areas. Rural residents are more likely to die from heart disease, cancer, unintentional injury, or stroke. Rural residents are more likely to have experienced adverse childhood events or ACEs, including household mental illness. And compared to urban children, rural children are more likely to experience a total of 4 or more ACEs. Rural residents are at a higher risk for suicide than urban residents. Suicide rates doubled between the years 2000 and 2020 in rural areas. And rural residents also face disparities regarding health. So they're less likely to receive healthcare of any kind, and less likely to receive evidence-based treatments when they do have access to care. They're most likely to, and they are most likely to receive any care or treatment for mental health within the primary care setting. And the gap between depression treatment needs and the available mental health workforce is particularly large in rural areas. So big demand and not enough people in the field. Collaborative care is an evidence-based approach to leverage limited mental health specialists for maximum population effects. So definitely can be a great approach in rural areas. Some advantages and disadvantages around rural primary care, though there is less access to specialty care in rural areas, including specialty behavioral health care. Primary care exists and can be less stigmatizing place to receive mental health care. Greater privacy is another important factor in small communities where everyone knows everyone's car. And parking in front of a community mental health center may feel, or a medical center probably feels less stigmatizing than being in front of a community mental health center. Some disadvantages include just a lack overall of resources, a lack of individuals who have expertise in behavioral health, and then some competing demands. So this could look different depending on the size of and resources of the community, but sometimes collaborative care programs are taking on more serious conditions that are typically referred to specialty behavioral health because they don't have those resources in their community. And then sometimes there maybe or those resources do exist, but are few and hard to access or takes a long time. So sometimes the collaborative care programs may be bridging patients until they can get them where they need to be. Slide. All right, so next I just want to discuss some of the research related to implementation in rural areas. So through a public-private partnership, the AIMS Center supported 8 rural primary care clinics serving low-income patients to implement collaborative care in the WAMI region. So those who don't know, the WAMI region includes Washington, Wyoming, Alaska, Montana, and Idaho. And this region makes up 27% of the landmass of the United States. So a pretty big area that covers. The sites were followed for 18 months after launching their collaborative care programs. And the study evaluated depression outcomes, clinical process of care, and primary care provider experiences. So the 8 clinics planned initially to serve about 3,250 patients, and they ultimately enrolled 5,392 patients. So just, yeah, a testament to what a huge demand there is and what need exists. And this represents 16% of the total unique patients served by these clinics, which is a significant increase to the patients they were able to reach before implementing collaborative care. The patients receiving collaborative care experienced clinically significant improvements in depression and reduction in suicidal ideation. The mean PHQ-9 depression score was 16.9 or 16.1 at baseline and 10.9 at the last individual measurement, which is a statistically and clinically significant improvement. And then primary care providers involved in this study also reported positive experiences overall. So this slide shows a comparison of the impact research study and the 8 rural FQHCs and tribal clinics that we were just reviewing. So just a reminder, impact was the largest randomized controlled trial of collaborative care to date. So we know that rural residents face significant health disparities. They're less likely to have access to mental health care of any kind. When they do have access, they're less likely to receive evidence-based care. They're less likely to improve compared to their urban and suburban counterparts. So in the impact study, about 45% of patients had a 50% or greater reduction in symptoms. And remember, that was twice as high as for usual care. So the impact study showed great results, in comparison to usual care. And as you can see from this graph, nearly all of the rural clinics were able to match the impact results or even do better. All right, and this is the Rural Mental Health Initiative Integration Initiative, and it was a 3.5 year partnership between Premera Blue Cross and the University of Washington Ames Center from about 2019 to 2022, and it was designed to expand access to evidence-based mental health treatment across rural areas. Um, so just to remember, in usual care, 20% of patients experience depression response. On average, 42% of the patients in this study achieved depression response. So a PHQ-9 score that had decreased by at least 50% from baseline to last measurement, and 34% received depression remission, so a PHQ-9 score that was lower than 5. And so these results are similar to the depression response observed in the IMPACT trial. And the clinics in this initiative outperform clinics from the other rural collaborative care initiatives in terms of average patient anxiety response. So clinics in other initiatives demonstrated an average anxiety response of about 26%, while the clinics in the Premera funded Rural Mental Health Integration Initiative achieved a much higher average anxiety response rate, which was about 42%. And by response, we're talking about a GAD-7 score that has decreased by 5 or more points from baseline to the last measurement. All right, so during the Premera study, the team used a mixed methods study to examine the barriers of implementing collaborative care in rural settings. Also found that some of the very prominent barriers experienced were COVID-19, of course, limited availability of site staff to participate in implementation activities. COVID really took a lot of staff time and energy. And then also many sites struggled to hire collaborative care staff. Yeah, there just, wasn't the expertise in the area. And so it was really hard to get applicants when trying to build your collaborative care team. And then some facilitators were PCP buy-in, making sure there's identifying a PCP champion was helpful. And then, promoting adaptability and organizing implementation team meetings, just having strong communication across the team was another facilitator of that helped with successful implementation. Managing metrics, having metrics to look at your program overall and the performance of your program, and having an effective registry was another facilitator. Now I'm going to pass it off to Kittitas Valley Health.
Greetings, everyone. Grateful to be a part of this panel today. My name is Oren O'Connell. I'm a psychiatric nurse practitioner functioning as a psychiatric consultant with Kittitas Valley Healthcare. Excuse my voice today. I have a bit of a frog in my throat. But Kittitas Valley Healthcare, who are we? Well, we are based out of Kittitas County in Washington State in the beautiful Pacific Northwest. Although we do business as Kittitas Valley Healthcare, we're actually part of a public hospital district, Kittitas County Public Hospital District number 1. We are rural and proudly independent. We do have a critical access hospital, urgent care clinic, and 9 outpatient clinics, 3 of which are actually rural healthcare clinics. I'm going to be talking from that perspective of launching collaborative care at 2 of our rural healthcare clinics. We launched collaborative care at our first rural healthcare clinic in Cle Elum in 2020, and then at our second rural healthcare clinic in Ellensburg in 2022. And then we're looking forward to hopefully launching collaborative care at our pediatric clinic here in the next 6 to 12 months. Next slide, please. So in speaking from my experience of launching collaborative care in rural healthcare clinics, I want to highlight a few takeaways. For us, collaborative care was really something that the clinical team was enthusiastic about. And so I put the maxim know thyself here to start out this slide. I'd like to say know thy team. For us, the barrier actually to launch was more so administration, bringing them up to speed as far as the benefits to our patient population and also our primary care providers as far as really helping to prevent burnout. So we had to speak the language of administration, do a lot of work with them. It took about a year to really win that hard support among administration. Some other important points that have been really beneficial and important for us is a strong program vision as you plan, reviewing that program vision with all members of the team, including administration, so they get an idea of what you're doing. And then we haven't had to do this yet, but it is really helpful with your program vision. If you can get a solid program vision from the beginning, then as you sustain your program, you can adjust your population as needed. For instance, we've talked about actually now increasing our PHQ-9 and GAD-7 scores prior to referral, just because we have had seasons where the caseload of our behavioral healthcare managers has been really creeping up there, and we obviously want to keep those caseloads manageable. We haven't had to do it yet, but that is an important mechanism we can put into force if needed, as far as how we coach our PCPs as we engage individuals into the program. Another aspect that's really been beneficial to us is spending time to really think about your clear team roles, and not only the team roles within the collaborative care model, which is really highlighted as far as our PCP champion, behavioral health care manager, and psychiatric consultant, but what are those support roles to each team member? And as we were discussing this as a team, we came up with the idea of supporting the behavioral health care manager with a medical assistant, because the behavioral health care manager is a provider just like anyone else on the team. And so we decided to create that role, and going to be talking shortly on some of the success that we've had with that role as well. And then, of course, the data. We actually use the AIMS caseload tracker. Full disclosure, we were part of the first and third cohort of the Rural Mental Health and Integration Initiative. That was really beneficial to us, very grateful for that. In the AIMS Center, we are using the AIMS caseload tracker and continue to do so. But we also have a separate data dashboard, and we take a lot of the data from our caseload statistics on our AIMS caseload tracker that we use for our data dashboard. But the data dashboard is more geared towards the language of administration, and we'll also be talking about that here briefly. Next slide, please. So this is something that I've really been excited about, and we didn't realize this, but this is not necessarily common in collaborative care, that the behavior or integrated behavioral health care for that matter, where the behavioral health providers actually have that dedicated MA support. And this behavioral health medical assistant really needs to be a special person, ideally somebody who's had experience at your rural clinic and is familiar with the community and the flow within the clinic, and coordinating, with the front desk and the various primary care providers. And of course, they need to have a keen interest in behavioral health. Within our model, we found that it is sustainable if we have one FTE medical assistant for every 2 FTE of behavioral health care managers. Now, the behavioral health medical assistant, like I said, key extension of our clinical team as far as a support role, and that this individual is really important, ensuring that we get our measures completed at each visit, ensuring that the primary care providers and the primary care providers medical assistant is following through with PHQ-9 and GAD-7. And when I first started actually at our rural healthcare clinic back in 2017 now, we did not routinely screen for depression or anxiety. So this was a big culture shift for us. But we found along the way that if we ask too much of the primary care providers, they don't have time to manage everything. So we found we can enlist other members of the team. But we've also found the same problems with behavioral healthcare managers. They get really busy and they can't always make that follow-up phone call. So they can delegate to the behavioral health medical assistant to check on a particular patient or patients that we know have a frequency of high no-show rates. We can pivot as needed and work with the patient, to ensure that we can get them into the clinic. As we know, in a rural environment, transportation can be a real barrier. Where we live, we are based on in the Cascades. Snoqualmie Pass, if you're familiar, is quite close to where we are. So we do sometimes get snowed in and have to then pivot to Zoom visits. And the medical assistant has been, again, really instrumental in sometimes 10 minutes before the visit, getting the patient on Zoom so we can make sure that visit happens. Additionally, we've had a real nice improvement in our show rate, and that if patients are canceling or we have little openings here or there, that the medical assistant is usually more aware of who may need to be seen sooner and coordinating getting them back on the schedule. And sometimes that means communicating with multiple family members. And again, these are things that the behavioral health care manager or even the front desk do not always have the time for in their day. So these are some of the basic expectations of our role as behavioral health medical assistant. It's been really helpful for us as far as measures completion across the team, show rates. And then I also like to talk about trauma-informed care. We do live in a rural area in Cle Elum. We used to have coal mines. There's, still even some generational trauma. We don't have any active coal mines any longer, but, the MA really gets to know these patients just like each member of the team. And little things like, hey, can you make sure that the lights are dim in the exam room when I come in because the bright lights really trigger me? Little things like that have been immensely helpful as far as trauma-informed care. All right, next slide, please. And then lastly, I do want to talk about our data dashboard. And again, this is different from the day-to-day caseload statistics that the psychiatric consultant and behavioral health care manager are using for, measurement-based treatment to target and ensuring, obviously, we're getting good clinical outcomes. But the data dashboard does incorporate some of the caseload statistics from the registry. But what I wanted to highlight is know thy team, know thyself. I think it's a good idea to have a dashboard. It's been successful for us to, again, speak the language of the other team members in the organization. When we were planning our launch, we decided that we would have, obviously different set of metrics at launch that we would track compared to after we've had the program going for 6 months to a year to ensure sustainability. So something that was really important for us was to track PCP engagement. And we did that by tracking PCP referrals to collaborative care. And it's a bell curve as innovation goes. And it did take some, PCPs some time to get on the collaborative care bandwagon, but it was really helpful for our PCP champion to know who wasn't making referrals or providing warm handoffs to a behavioral health care manager, who is still trying to manage everything on our own. And that's really common in rural health. Rural health primary care providers are very independent. And that's a protective mechanism in some ways to, help them help the community. But obviously, collaborative care is a shift. It was a shift for us at Kittitas Valley Healthcare. I will say pretty much all of our primary care providers are quite engaged now. The challenge that we've experienced now is not so much our seasoned primary care providers, but how do we correctly train and onboard our new providers correctly, and how do we prevent burnout among our new providers? And we're still doing work around this, but our key performance indicators are based now on the quadruple aim as far as our data dashboard. And we do review not only our caseload statistics, but our data dashboard. We review this data across the entire team. So we're reviewing the registry data within the weekly caseload review. We have a monthly behavioral health coordination group, which all the PCPs are invited to, but it's primarily the psychiatric consultant and behavioral healthcare managers. But we also celebrate success and highlight the data from largely our caseload statistics at our monthly PCP provider meetings. And that's been a great opportunity for the primary care providers to ask questions and obviously highlight the success of the program. And then when administration joins us in our monthly meetings, we do review our data dashboard as far as our key performance indicators.
Hi, everyone. I am Stephanie Huber, LICSW and Behavioral Healthcare Manager at One Community Health. We are a nonprofit, you can move to the next slide. We're a nonprofit federally qualified health center in the Columbia Gorge. So that encompasses 4 counties between Oregon and Washington. And in January of 2024, our Washington clinics merged with One Community Health. So my workplace is still pretty new to One Community Health. We were privately owned by physicians before, so the move to federal funding has brought a lot more resources and access to our Washington clinics, which has been great. And we utilize CoCM in our White Salmon Clinic in Kittitas County, which we started as part of the Primera Rural Mental Health Integration Initiative grant. So we started CoCM in late 2021 at our White Salmon Clinic. Our psychiatric consultant, Kate Cousineau, was really the champion for this, getting this project up and running here. And I was hired about 6 months into the grant in March of 2022. So we started seeing patients around then. And we just hired a second behavioral health care manager in April of 2024, Canberra Johnson. So we have 6 doctors and 4 physician's assistants at our clinic, many of whom are serving multiple clinics. So prior to CoCM, we did have integrated long-term mental health care, which we still have. There are a lot of long wait lists, pretty limited access for private insurance and Medicare. And so there was just a big gap of people we were missing. And a big reason why Kate wanted to bring this to our clinic is because we want to be able to offer psychiatric care to folks who maybe didn't meet the needs of going to a community mental health care clinic, but most folks are getting their psychiatric meds from their primary care doctors, and their primary care doctors have limited time, limited knowledge in psychiatric meds, and if the first trial doesn't work, they're often at a loss, and we're pulling Kate in anyway for support. So this allows Kate to consult on many more clients and help folks get onto relatively routine medications with a lot more ease without overloading her schedule. And so we also, prior to CoCM, didn't have a lot of screening, like Oren was saying, for behavioral health conditions in a routine way. And so as part of this implementation, we have them at all of our annual wellness visits, as well as when there's any concern for a mental health condition. And just for context, our kind of payer scale breaks down to about 30% Medicare patients, 30% Medicaid patients, 35% commercial, and 5% self-pay. So we do have a pretty high percentage of Medicare and commercial patients. So in terms of intakes, we utilize the PHQ-9 for depression symptoms, the GAD-7 for anxiety symptoms, as well as the CIDI for screening for mood symptoms or bipolar at each intake. And then using the PHQ-9 and GAD-7 at follow-ups. And then additionally, we will use the PCL5 for trauma, the EDEQ for eating disorders, and the Y box for obsessive compulsive disorder, if that feels applicable. We also use the ACT caseload tracker. We do not have a kind of minimum score on the PHQ-9 GAD-7 in order to be referred to CoCM. It's certainly something we've discussed, but we've kind of kept that open to interpretation for now. On the PCP's part, with, of course, the ability for them to run cases past us. And we do the program pretty much to fidelity, with the exception of implementing 90-minute intakes. This has been a huge help for me. It allows me to get a more complete medication history and mental health history. Sometimes even being able to start with a little bit of skill building in the intake, and it allows us to jump into therapy in the first session. Whereas I was finding with the 60-minute intakes, especially if somebody showed up late, like there was just a lot of information I was missing by the time we got to our first session. And given that there's such short sessions with limited amounts of sessions, it was pretty challenging for myself and for clients. So as both Annie and Oren have mentioned, right, there are really limited resources in our county, which is super common in rural mental health. In 2023, we ended up losing our community mental health and substance use office. And so we've had no community mental health or substance use treatment in Klickitat County for about 1.5 years, which is really hard, right? There's few to no private providers contracted with Medicaid in Klickitat County. So there's a big portion of our population that just can't access the care they need. And so that's meant we've had to be a little bit more creative here in like who we are seeing and kind of expanding who we are seeing in cases where we would normally maybe send them to a higher level of care or over to community mental health, right? That simply doesn't exist. So it's just required a lot of collaboration with our psychiatric consultant, Kate, and with the primary care doctors. Because the nearest place to get, like IOP would be Vancouver or Portland, which is about an hour away. And it's been really hard to hire providers here. When I first started, there were 4 other therapists, including my supervisor. And by December of 2023, it was just my supervisor and I. And we weren't able to hire any new providers until this year. And now we're finally getting back to fully staffed, which is awesome in the behavioral health department. But we're still definitely scrambling to kind of rebuild and recalibrate from not having enough providers for so long. And so that meant we had really long wait lists for a long time that we're still working through. And another hard part about not having enough providers, right, is Canberra and I, who are the 2 doing CoCM as well as long-term therapy, we're both white cis women of similar ages, right? We don't speak Spanish. We are missing, kind of big gaps in the population. So yeah, this has just meant we've had to pivot a lot and hang on to patients longer at certain times or take on patients we would normally refer elsewhere. So we've had to do a lot of education for the PCPs on who to refer versus not refer, but all of our PCPs are referring. We have noticed a challenge is like when we get new primary care doctors, making sure that we give them that education on who is appropriate to refer to CoCM versus long-term versus referring out, which is really hard when there's not many places to refer. And we're kind of the only game in town right now in terms of mental health outside of private providers. So that often means working with multiple family members. We do have a policy of not seeing folks from the same family at the same time for the behavioral health care managers, but it's really common to let the PCP know, like, hey, there's a conflict of interest, but you can refer them in 3 to 6 months. And really common for us to see folks from multiple family members from the same family. So CoCM has really allowed us to bridge this gap of psychiatric care for lower acuity patients who have nowhere else to go. Okay, next slide, please. So cultural and social factors, Annie mentioned a lot of this, right? Like there's a lot of resistance to therapy in rural communities. But something that's really been great to see is the good rapport and relationships that patients have with their PCPs. They really trust them. And so oftentimes when a PCP will recommend therapy, patients will really listen and consider that, where they admit they probably wouldn't have before. And being able to say like, hey, this is short term, this is skill based, right? This isn't something that you need to do long term if you don't want to. It's really allowed a lot more people to come to therapy for the first time, which has been so cool to see. And a lot of older clients who had never done therapy before, now in their 60s, 70s, and 80s, seeking therapy for the first time. And having those services in-house is really reduces that barrier to entry, right? People don't know why you're at the doctor's office. It could be for a huge number of reasons, right? And we have a door. I have a door really close to my office, so folks are able to just like exit into the parking lot instead of having to go back into the lobby and likely seeing somebody they know. But people do have a lot of privacy concerns. We are a collection of small towns, and it's really common for people to not want to seek therapy in their hometown, right? Where everybody already kind of knows a lot of their business. So we do see folks from, all the counties around us, right? From Skamania County, where we have another clinic that's not staffed with CoCM, as well as from some of the counties in Oregon, because, their mother-in-law or their best friend's dad works at the community mental health. And it just doesn't feel comfortable for them to seek services there. And then telehealth is, of course, a big need in our county due to us being so rural, right? There's folks who live 30, 45, 60 minutes from white salmon. And gas is expensive. In the winter, it can be pretty treacherous. So we definitely utilize telehealth, phone and video. But that's always a conversation, right? We are not offering that we're not offering that immediately. We're always trying to make sure it is clinically appropriate, right? But we do offer phone as well because internet is so expensive and can be difficult to get out here. For a lot of people, the only option is Starlink, satellite internet. And that's just out of a lot of people's reach. So telehealth has been really helpful for that. Or, like Lauren said, when our clinics close down, because there's so much snow, right? People just can't get here and we need to pivot to Zoom or phone. Or the internet's been knocked out because we're rural and it's the only option. So I just wanted to kind of end with a metaphor. One of our PCPs calls CoCM roadside assistance, right? It's going to help you. We're going to help you by meeting you where you're at and getting you where you need to go, right? We might not be the end all be all. Maybe you just have a flat tire, right? We can help you put your donut on. You can get to the mechanic, right? Or we can help you patch your tire or get your keys out of the car and help you get back on the road and back to living in your power, right? And sometimes that means we are helping you get to the mechanic so you can get a whole new timing belt, right? Or get your engine replaced. Maybe you actually do need that higher level of care. And part of what we are doing here is just kind of helping you learn a few skills and figure out how to access that higher level of care, because a lot of people just don't even know where to begin. And that's where that kind of case management piece can come in addition to therapy. But it's been so gratifying seeing patients who, have never done therapy before. They just retired, right? They're like, I don't know if I want this or if this could be helpful. They get on maybe the right medication finally, and they learn some skills and they're feeling like themselves again, right? It's just been so cool to see that and to really reduce those barriers. Okay, thank you.
Thank you all. Many thanks to all of our presenters. It's always so valuable to hear from those of you who are stepping up to kind of figure all this out and willing to share your learning and lived experience with all of us that you're having or have gone through. And so we're going to turn over now to our Q&A section of our program today. There were a couple of questions that came through. I really appreciated hearing from all of you kind of the more health equity lens of things about the patient-centered approaches and the barriers that you are trying to overcome for the patients that you're serving. There is a question that we often get around staffing, and I've heard all three of you kind of mention that being a challenge one time or another with staffing. And so I'm just wondering if all of you or any of you could speak to what you have done or tried to implement to overcome the hiring staffing component to hiring people, good people to work in your clinics.
I'll talk, excuse me, I'll talk briefly. It really has been a challenge, especially with behavioral health care managers and particularly. However, being in a rural area in a small community, a lot of our hires have been through word of mouth of, hey, we're doing something exciting, really trying to benefit the community. And it sparked interest. It's a long game. So it has taken us a while to build, a solid team. And then on the other side, though, I will say the unintended consequences, and we're still trying to figure out what this looks long term, but we have found less turnover with our primary care providers. A lot of the PCPs would come to our clinics to get loan repayment, and then they'd be gone within a couple of years. So we are seeing less burden on them as far as these complex patients with that roadside assistance. I like that analogy.
It was a good analogy. I liked it too. Stephanie, how about for you guys?
Um, yeah, it's definitely been a challenge trying to hire, particularly behavioral healthcare managers. That's really the only role that we've been trying to fill since our psychiatric consultant is also our psych PA here in house. I wish I had some magic advice. I really don't. We did hire somebody last year who started and was here for like a month and ended up leaving, but we were trying to hire someone like a second BHCM since I started, and it really took till April. Um,
Okay. So how many months was that around from when you started until April?
so I started, it was 2 years and 1 month.
Okay. Okay.
Yeah.
All right. So just something that it sounds like for consideration when beginning with implementation or trying to implement collaborative care to think about the timing that it might take to hire staff. One of the other questions that was asked in the Q&A chat here is around the behavioral health care manager and whether or not they follow kind of a manualized treatment for common anxiety and depression diagnosis. So wondering, Annie, if you could talk any to what you've kind of seen with the behavioral health care managers, and then Oren and Stephanie, what you all do at your locations for individuals you hire. Are they following a manualized treatment of some sort, or what's happening out there?
Yeah, I can start that one off. Yeah, not necessarily. It's the goal is to use evidence-based treatments. So ideally using things like problem-solving treatment, behavioral activation, CBT, things that we know have evidence base, and also interventions that are also conducive to a primary care environment and episodes of care and brief visits. But as far as kind of determining diagnosis and what interventions are used, ideally it's based on, the intervention pieces, should include the patient and patient choice, but then as far as assigning a diagnosis, that really depends on the role, who's in that BHCM role. And so sometimes there's organizations that maybe have a nurse as the behavioral health care manager or a bachelor's trained individual as the behavioral health care manager. So in that setting, that diagnostic piece may be brought to the systematic caseload review for the psychiatric consultant to assist with that part. Others, organizations maybe use a psychologist, or most use a licensed, mental health provider who can determine a diagnosis and confirm that maybe with the psych consultant. But someone fresh out of school is different than someone who's been in the field for a while. So it really needs to be developed based on who's in the role and what their needs are and where they're kind of at. But so I would say it really, really varies across sites, but overall sites, should be using evidence-based brief interventions, and those can be used by a wide range of behavioral health care managers. So whether it's an RN or an LICSW, those care managers can use things like behavioral activation and things that we know are helpful in treating depression.
Gotcha. Thanks, Annie. Stephanie, what are your behavioral health care managers utilizing, if anything, or how do you all approach that?
Yeah, we do use a lot of CBT and behavioral activation. My coworker, Canberra, who does CoCM as well, uses a lot of DBT skills. And yeah, it's pretty similar to what Annie was saying, right? It depends on the client and on the clinician. And some clients really want that like container and kind of like more manualized treatment. And some patients like really don't jive with that, right? And so it's a lot of creativity of how do we do that in the short session.
Gotcha. Thanks, Stephanie. Oren, anything to add to that?
Yeah, we we definitely don't practice, cookbook interventions necessarily. Each behavioral health care manager has their own autonomy to obviously meet the patient where they're at. But I like to call it minimum expectations, and we expect that every single patient has a safety plan, has an initial behavioral health assessment, so on and so forth. We actually have our swim lanes outlined as far as expectations of the BHCM, the behavioral health medical assistant, the primary care provider, and the psychiatric consultant. And that keeps us accountable as far as fidelity to collaborative care. But our behavioral health care managers are diverse in their skill set. And so, we have one BHCM who prefers to only see adults, is willing to see teenagers, prefers not to see children. That can be tricky in a rural environment, but I think you just have to know the needs of your institution, before you hire. But we've really tried to be flexible because it is so difficult to find good people. And then another thing, actually, coming back to staffing workforce, I just wanted to mention we have found that our BHCMs, can be a little tricky at times, really love 410s. And you see that trend across the country for better work-life balance. So we have given our primary care providers and now our BHCMs that opportunity if they prefer to work 410s over 5/8s.
Which is also another strategy for hiring, right? And recruiting and getting people who are interested in working a more flexible schedule. Gotcha. One of the things that came up in the Q&A box was around kind of the behavioral health care managers' backgrounds that you found and that you hired, and just what went into, Oren, for you, what kind of went into coming up with the idea of a behavioral health medical assistant, and determining that you need one of them for two behavioral health care managers.
Yeah, again, so we have a diverse background. And actually, one of our behavioral healthcare managers was an LICSW working as a hospital social worker who had in years past supervised other LICSWs. But when we told her about the program, what we were doing, we were underutilizing her license in the hospital. And so we were actually able to bring her on board as a behavioral healthcare manager. And she's been in the community for many years, is really familiar with the local resources, but it has been more of a learning curve for her to get up to speed with brief interventions. But she completed training course in problem solving therapy and behavioral activation. She's doing great, and you can't really teach therapeutic rapport, especially in a rural setting. So if you have somebody who's eager and they still need to learn, some of the clinical skills as far as evidence-based care. I'm happy to do that as a psychiatric consultant in our weekly caseload review. We just have to take a little bit more, time in some of our meetings to review interventions and what that looks like. But as far as the medical assistant and that role, as far as support to behavioral health care managers, it works for us because we're a rural healthcare clinic, and we actually, do get a subsidy based on our encounter rates at the end of the year. So based on our performance, I'm not sure this model is necessarily going to work for everyone. However, I will say that having that medical assistant has enabled the behavioral healthcare manager to have more time to, see patients throughout the day and prioritizing, patient contact versus, some of the data entry and other, pieces of administration that can be a creep on time.
Gotcha. Thanks, Oren. Stephanie, what's the background for your behavioral health care managers?
Yeah, so I'm an LACSW, which I got my license this year. So I started as an associate here. And then Canberra is an associate level counselor. So we both have master's degrees and experience in therapy.
Gotcha. There was a question around what your caseloads look like. So how many active cases does one behavioral health care manager carry, and the age ranges that your behavioral health care managers see?
Yeah, so both Canberra and I are part-time, doing CoCM part-time because we both also do long-term. So we each do two full-time days. Um, so sorry, I got distracted by the chat. um, so, and now I lost the thread completely. What am I trying to say? How many patients? We see about 40 patients. We each have about, yeah, like 30 to 40 patients, kind of depending on the caseload and how busy things are. And I think there was a second part to that question, but I forgot it.
Well, just in terms of your caseloads and then the age ranges.
Oh, the age ranges. So for us at our clinic, CoCM is for 18 and older only. Neither of us have a passion for working with children, and so we've just kind of kept that rule. It was something we started with the idea that we could flex it, but I personally don't want to work with kids, and neither does Canberra. So we've kept it at 18 and older, but I think the oldest client I've had is like their late 80s. So it's a really big age range.
Gotcha. Any keys to sustainability in rural health and providing collaborative care in rural health?
From my viewpoint, the caseload size is very important. Our behavioral health care managers, we shoot from no more than 70 patients. If we start to get up to 80, we have to take action to, close out individuals who are good candidates for relapse prevention. And then if we start to get below 60, we start asking the primary care provider questions, because we always know that there's individuals in our clinics with depression and anxiety. It's just a matter of whether or not we're finding those individuals in the community. And that may be somebody hasn't seen their primary care provider in 5 years. So what's an initiative to get, people back engaged into preventative services? So as far as caseload, very important for sustainability. What was the second part of your question, Monica?
Earlier when we were talking about, no, that's fine. So it was about sustainability. So caseload size, it sounds like you answered that part. Earlier when we were talking about caseload sizes, we were also talking about the age ranges that
Oh,
your behavioral health care managers see.
yeah, and then for us, it's basically school age until end of life. But again, I really feel strongly that that's gonna really depend on the interest of your team. If you have team members who are interested in seeing children, then I think you should pivot, focus on your adult population. I think you should really meet the needs of your team, but I also think if you're not meeting the needs of your patient population, then that should be a different conversation.
Gotcha. So how to make sure you're kind of balancing that scale a little bit. Okay. Gotcha. Annie, any thoughts from you on sustainability in rural health, providing collaborative care in rural health?
Um, I mean, I mentioned a little bit earlier, but just, yeah, having buy-in, I think is really, really important. And I think it was Stephanie who had mentioned just, or Oren actually, just kind of the autonomy of PCPs and, maybe some resistance. It definitely is helpful in, the different rural implementations that I've assisted with to just have really strong PCP champions who are able to just, dispel myths or concerns, have conversations and provide, data from their own experiences. And we can give all sorts of data around the benefits and success of collaborative care. But I think rural sites, it's like, but we're different, and it is different, but it also can work. So I think once, if you can start kind of with a pilot and have a PCP champion that's seeing some patients, and then being able to bring others on board with their own data and to show how this has been implemented in their actual setting versus using kind of other people's data, I think that has been helpful. So kind of starting smaller, but making sure you have someone that is able to connect with those PCPs and bring them on board. And yeah.
Gotcha. Thank you all so much. We did not, of course, get to all of our Q&A questions, and quite a few that were in there around kind of the financing and billing side of everything. So Christy, who is, as I mentioned, behind the scene logistics for us here, will drop in the chat the links and information for our implementation, as well as office finance hours. I encourage you all to please come to our finance office hours that we hold every month. It's a great opportunity to get some of those in the weeds questions answered about providing collaborative care, whether it's in a rural healthcare setting or not. The individuals that we have on the call there are always able to answer the questions or research and come back with a response, because that is one thing I do love about the collaborative care community. We are a community and learn from each other. So I appreciate that. So if any of you had those more minute in the weeds questions, please feel free to come to the finance or implementation office hours to get your questions answered there. Here are some additional resources for those who are interested. I've put the links here. This recording will go out to you, so you will also get this to have. But some information around the evidence base for collaborative care, articles on navigating barriers in uh, providing collaborative care in rural settings, and then also a rural community health toolkit that has a lot of information there around kind of health equity principles and some of the barriers and things that you heard about today in hiring and getting patients to where they need to be for care. So those resources are there for you. And here is the dates for our upcoming quarterly webinars. There were some statements made about individuals knowing other sites that have behavioral health medical assistance. We have discussed that actually before on previous webinars. So if you all did not know, we record these webinars and they are posted on our AIM Center website. So if you ever want to go back and watch something, and we're going to continue throughout 2025. So these are the dates for our 2025 quarterly webinars. They always happen at 10 a.m. Pacific time, and we welcome you all providing feedback to us, not only about the webinar from today, but also if there are topics that you are interested in hearing or seeing covered during a hour-long quarterly webinar series. Please, please, please send that information our way so that we can make sure we are listening to your voice and providing some additional resources and information to you that would be helpful. So we thank you for attending today. You have a short minute to go and do bio and water and all of those things. And we hope that you have a great rock star rest of your day.